Hello everyone, this is Dr. Pruett. Welcome to a fun new initiative starting with 12-lead interpretation. This is going to be the foundational lecture of basics of 12-lead interpretation that we're going to refer back to every week as we start to do weekly EKGs together. This is going to be the basics of 12-lead interpretation today. And I know when I first started in medicine, and I suspect for a lot of you folks too, when you first looked at a 12-lead, it looked like a bunch of squiggly lines that made absolutely no sense. And so the idea today is to hopefully make some sense out of those lines and be able to understand what's going on with the heart electrically when we look at these 12 leads. And so the 12-lead is all about electrical conduction, and this is done by exchange of sodium and potassium and calcium in the heart, which creates electrical potentials. It's simple electricity, just based on anions and cations, positive charges and negative charges in the heart that exchange to make it beat. Pretty simple, right? And so the electrical conduction pathway starts in the right atrium on the right side of the heart, very high in the sinoatrial node. This is where we get our sinus rhythm from. This node right here is designed to regulate the heartbeat between 60 and 100 times a minute. It is set to that rate in general. It can go higher, it can go lower, but in general, that's where it should be. It sends a signal down to the AV node, which is still in the right atrium above the ventricles, that holds the signal for just a second before it sends the message down to the right side. Since the left side is so big, it has two pathways to send to the left side because that's a big muscle that needs to contract really strongly. And so the left bundles, there's two of those. Sometimes there's new evidence that there may be three that we're learning about a little bit more, but classic teaching is there's two left bundles, an anterior one and a posterior one. And on the right side, it's a little bit smaller and weaker, so there's one right-sided bundle there to conduct the electricity and tell the heart to squeeze. And so real quick review, sinus node up in the right atrium goes to the AV node where it pauses for a second to send messages to the ventricles to contract and send blood out of the heart, either to the lungs to get oxygen or to the body to deliver oxygen. And so when we think about the electrical conduction pathways, we can see how those pathways are functioning when we look at the EKG. The sinoatrial node, when it contracts, we get the P wave. We get the signal from the sinoatrial node, tells the atria to send the blood into the ventricles to get ready to go to the rest of the body. So when the sinoatrial node contracts, atria contract, and then we get our P wave. That's what we see on the 12 lead. So the P wave corresponds to sinoatrial node conduction in either of the atria, the right side or the left side. Our big QRS complexes, the big spikes that we see on the 12 leads, the reason they're so big is because the left ventricle is so muscular. It requires a big depolarization. So that's a big movement of charge because the signal has now moved from the AV node into the ventricles. The ventricles squeeze all the blood out, and we see this big QRS complex here. That's what you're seeing when you see the QRS complex. Those are functionally your heartbeats, where blood is being ejected from the heart. And then lastly, everything has to reset. And so when we see our T wave here, after the QRS complex, it takes a little bit of time for the ventricles to get ready to repolarize and beat again. And so what you're seeing when you look at a strip is a P wave showing the atria is contracting, the QRS showing that the ventricles are contracting, and then the T wave showing you that everything is resetting. Now you may be asking, well, the atria need to reset too, right? Well, yes, they do, but the reset is so small and it happens at the same time that the QRS is depolarizing, so we don't typically see atrial repolarization because it's buried in the QRS somewhere. So when you look at it on a strip, this is probably much more familiar to everyone. What you see here is just what we talked about. So you see the P wave before the QRS complex. This is your atria depolarizing and sending blood into the ventricles. You see your QRS, the big voltage, big squeeze, blood being sent to the body. And then our T wave is our repolarization. Ventricles are getting ready to do this again. And if you take this from one strip, looking at the heart from one angle, you can actually look at the heart from 12 different angles. And this tells you a whole lot about what's going on in different sides and different aspects of the heart. And so we'll go through each of these 12 aspects of the heart, but basically you're seeing the same thing. So you're still seeing your P wave, you're still seeing your QRSs, and you're still seeing your T wave. So atria are contracting, ventricles are depolarizing, ventricles are repolarizing. But you see that from 12 different angles, and they all have different labels and titles. And the reason they do is because they're all looking at different parts of the heart. So this is why where you put your stickers on your patient's chest really matters. So when you're putting that first sticker on the chest, you want to go down to the fourth rib, kind of just to the side of the sternum. That's V1, and then you go from there, V2, V3, V4, V5, Z6. Well, what you're looking at, you're literally over the left side of the heart, you're putting your stickers right over that big left anterior descending artery there. And so your sticker placement is getting a really good look. Your stickers that are on the chest, they're getting a really good look at the left side of the heart, okay? And your other ones, 2-3 AVF, 1 in AVR. 2-3 and AVF kind of look at the right side, okay? AVR kind of looks at the back. So each one of them have an aspect that's going to tell you what's going on as we're doing our best to look at the heart as a whole. And the reason we do that is they're going to pick up electrical conduction, but they're also telling us about what those arteries are doing in the heart. And so again, if you look at your vascular territories, the big coronary arteries, you basically, there's more than 3, but there's probably 3 that you need to know, and we'll learn through the course of this series. But your big left anterior descending is your main one. This one's called the widowmaker. If it gets blocked, the heart stops to work, and then you have the big heart attack, and most people don't survive that. You have a left circumflex that kind of goes off to the side, and then you have an artery that feeds the right side of the heart. And so when we're looking, I'll start from left to right just because we're used to reading that way. When I look at an EKG, I tend to start with my inferior leads just because they're easy and that's where my eyes naturally go. But I look at 2, 3, and AVF. And what you're looking for, if you have any kind of ischemia or problems with blood flow, is ST elevation. There's something wrong between the time the ventricles depolarize and the time that they repolarize, indicating that there's a vascular problem. So I start with 2, 3 AVF, and this is where they're located on your 12 lead. And what they're looking at here, you can see here on this right side of the heart, 2, 3 AVF are looking very much on the right side of the heart and at this right coronary artery here, the right atrium, the right ventricle. And interestingly, what's housed in the right atrium, right, remember, is the sinoatrial node and the AV node. And so a lot of times if there's problems in this vascular territory, you're also going to have electrical conduction problems. So you can lead to blocks, you can lead to bradycardia, things like that with the inferior leads, because this is where the majority of your electrical conduction system is located. 1 and AVL are looking a little bit higher. And then you move over, I kind of see this as the right side of the heart and the left side of the heart. So as you move over to V1, V2, V3 through V6, again, you're kind of looking at that left anterior descending artery. First you have your septum, which is the big muscle that divides the right side from the left side. And then as you move over, you're kind of moving around that corner of the heart, looking underneath the armpit there at the lateral aspect of the heart. And that's where you get to 5 and 6. And sometimes you get a really high lateral lesion that you'll see on 1 and AVL. But basically, if you divide your 12 lead into these vascular territories, you're going to be able to tell a lot about what is going on with the different areas of blood supply. So we're going to make this really simple. I know I just said a whole lot, but we're going to do, my favorite thing to do is the same way every single time, and that way you don't miss things. So we're going to do this every single time we look at a 12 lead. We're going to look at our rate, rhythm, axis, intervals, and ST segments. 5 simple things every single time, and it'll give you a really good idea what's going on with the heart. So the rate, there's 3 ways to determine it. I prefer things to be easy the majority of the time, and so thankfully, we have computers that do a lot of calculations for us. They tell us the rate right up here at the top. Now, A downside of that is they're not always totally correct. But I do tend to look at that first and just see, is it fast? Is it slow? Does it look like it's about the right range? And then I can confirm with my eyes with what the computer says. Now there's two other ways to really know what the rate is. And really remember, the big QRS complexes are when the heart beats, the ventricles eject the blood to either the lungs or the body. So it's easy to count the pulse or conducted beats by counting your QRSs. And the way I like to count the QRS is a quick and easy way to do this is if you look at your QRS, you find one that matches up with a thick red line. So here we have one QRS that just happens to line up with a thick red line right here. And then you count. You have to memorize these numbers here, but you do it a couple times and you'll figure it out. So you start with, you just count down 300, 150, 100, 75, 60. And since your next QRS falls between 60 and 75, you know you're somewhere in a normal range. It doesn't give you an exact amount, but you know if you're closer this way, you're very fast. If you're closer this way, you're very slow. And then you have a ballpark area of where your heart rate's falling, right? Pretty easy to eyeball that way. Another way to do it, and this one involves math, so I'll be honest, I do this one a little less frequently, but for those of you that do like numbers, all you have to do, we know that our strip is a 10-second strip. There's 60 seconds in a minute, and so we count our QRSs 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13 times 6, which again is math. I would probably have to pull out my calculator for this, I'm ashamed to admit, but that gives you an accurate heart rate of 78. So those are 3 ways to calculate rate. I tend to like to look at the computer, confirm with my eyes really quickly, and then you have your rate. Next, we move on to rhythm. And so we have 2 questions that we need to answer with rhythm. First is there a P wave before every QRS? And if you'll remember, the P wave is what's reflected that the atria are depolarizing, sending blood into the ventricles. And so the indication of that is a P wave before every QRS complex. And if you do see a P wave before every QRS complex, that tells you you have a sinus rhythm. So if you hear normal sinus rhythm, what that's indicating is there's a P wave before every QRS. And then next, we look at our QRS complexes themselves. And the only question here, because we're looking at rhythm, is it regular or irregular? And my favorite way to do this, your eyes will trick you. I'll tell you that a couple of times. But what you can do is take a piece of paper and just put hash marks where your first 2 QRS complexes are. And then you know how far those are, and you can do 3 if you want to. And then you take your piece of paper and you march it down your 12 lead and see if there's any discrepancy between those QRS complexes, and if they move or if the beat becomes irregular, then you have an irregular heartbeat. And I would tell you, the faster the heart rate gets, the more subtle this gets to see. And so it really is a good practice if you're curious about the rate and if it's regular or irregular to do these hash marks on a separate sheet of paper and see if it marches out. And that'll tell you the regularity. Next, we move on to axis, and this is kind of fun. You get to use your thumbs for this. Left thumb is going to be lead 1, and your right thumb is going to be lead AVF. And what we're going to do is simply look at the direction of the QRS in lead 1 and in lead AVF. And so if we do that together here, which way is the QRS complex pointing? It's pointing up, right? The most of the QRS is up. So since my left hand is lead 1, I have a thumbs up on my left hand, right? And then I look at AVF, and the majority of this QRS complex is up as well. And so I have up in my left thumb, up in my right thumb, 2 thumbs up. That's really good. My axis is normal, okay? There we go. Normal axis. That's good. So if we start to talk about axis deviation, which I'll explain in another talk, but first here we're just learning how to do it. So we're looking at lead 1 and lead AVF again. So in lead 1, is it mostly up or down? I would say this is mostly up. So I have a left thumb up. Lead AVF, is this mostly up or mostly down? I would say this is mostly down. So what we have here is left axis deviation. So whichever thumb is up is the way that the axis is going. And here's a look at right axis deviation, same thing. Looking at lead 1 and lead AVF, is this QRS mostly up or down? I'd say this is mostly down. My left thumb is down. Right actually looks like it's up, right? And so I have left thumb down, right thumb up, I have right axis deviation. Okay, so we'll talk about the importance of that later as long as you know how to measure it. Pretty straightforward. Next, we move on to intervals. I would argue everybody likes to look for STEMIs, and those are very important, I would agree. But things that we can affect in terms of importance that tends to get overlooked, I would argue that these two things are very important, especially our QTC. This is one of the first things I look at when I get handed a 12 lead, because I have the ability to either make that worse or make it better by the medications that I give. So first, let's look at the QRS, and that is simply just the width of the distance that it takes for those ventricles to contract. A nice healthy ventricle is primed and ready to go and is going to squeeze very quickly and very forcefully. A kind of sicker ventricle that may have a bundle branch block or some sick heart cells that aren't quite working right may take a longer time to squeeze. And so the way that's going to be indicated on your 12 lead is that this is going to get really wide. And the number that we're looking for here is 120. Your QRS should be less than 120. Okay, a wide QRS has a lot of other implications that you need to think about. But if it's less than 120, you're probably good to go. The next one we look at is QTC. This is your QT interval, the distance between the time that the ventricle contracts to the time that it's ready to go again, right? This is depolarization, this is repolarization. Now it's ready for another squeeze, right? This should be less than 500. Anything over 500 is at risk for spontaneous torsades. That's bad. So 450 is actually where I start to take notice. 500 is where I may proactively either aggressively keep an eye on it or try to do something to make it shorter. Two very important numbers. So 450 is abnormal, 500 is at risk for spontaneous arrhythmia. And the way that we do this, I will be completely honest again, I don't love math, and so good thing computers are very good at math. These are very reliable numbers here. And so don't be afraid to look up at the numbers on your 12 lead. I would not encourage you to read the words to interpret it for you. You're going to be able to interpret your own now. But what I do want you to do is look at these numbers. So our QRS here, the magic number is 120, right? And that's milliseconds. This is given in seconds. And so this would be 86 milliseconds, right? So it's less than 120. That means it's good. And you can look here too, like it looks like a nice narrow QRS, right? And so always confirm with your eyes what you see on the squiggly lines, but you can use the numbers that the computer gives you here. And then your QTC is interpreted over here, and this one is 424. So again, less than 450, definitely less than 500. I'm happy with that, and my eyes tell me that that looks like a normal repolarization as well. So as we're looking at our intervals, the two most important are QRS and QT. And then lastly, we get to move to our ST segments. This is where everybody wants to jump to first, but you can see, just based on the last couple of minutes, how much we would miss if we overlook those first four steps. And so we save our ST segments for last. And really what you're looking for here is either ST elevation, so remember here's Q, R, S, T, right? And if your S wave starts to raise and goes kind of flat to the T wave, that's dangerous and could indicate that somebody's having a heart attack, especially if it's above the baseline greater than one millimeter. And that's what you're looking for. And sometimes you can have ischemia depicted by inverted and depressed T waves as well. And again, what we're looking at is vascular territories here. So when you start to think about ST segments, this is where I look at the 12 lead and those vascular territories that we talked about first. And so what we notice here, 2, 3, and AVF are our inferior leads, and they're looking at this right side of the heart, right? Right here, here's your left anterior descending that kind of divides right and left. And they're telling you what's going on the right side. And what we see here is a little bit of elevation from the baseline into 3 in AVF. And so we do have our first criteria of greater than 1 millimeter of elevation in contiguous leads. So the contiguous just means they're looking at the same part of the heart. The next thing you need to call a STEMI is that the opposite side of the heart is also showing ischemia. So in this case, our reciprocal changes is what they're called. And that just means the other side of looking at it is that we have depressions. And so in the side that's having the problem, you'll see elevations. And in the side that's on the opposite side of the problem, you'll see depressions. And so we see depressions here in AVL and 1. Do you see here the baseline is here? And that ST segment is depressed. Same thing here. It's a little more subtle, but it's at least 1 box. And so that is a definite vascular territory because 1 in AVL, if you look, if our problem is on this side of the heart, right, with 2-3 AVF, 1 in AVL are looking at the back side, and they're telling you that they're looking this way, seeing a problem. These are looking this way, seeing a problem. So your problem is right over here somewhere. And then you can still look at the rest of your vascular territories as well. So all of these are your anterior leads. Some of these are higher lateral. I don't really see if it's a big infarct. You may see this extend all the way. If 1 in AVL are seeing reciprocal changes, sometimes you can also see reciprocal changes with an inferior STEMI in V5 and V6. We don't see that here, but that's another place to look. And then here's an anteroseptal STEMI. So same thing, we're looking at our ST segments now. So you've already looked at your P waves, your intervals, axis, everything else. Now you're looking at your ST segments. And what do you see here? But the septal and lateral leads. So we're looking at V1, V2, V3, V4, V5, right here in this left main territory, right along the septum. Big left-sided heart attack. We see ST elevation, here's your baseline, and that ST segment is high above the baseline. This is what we call tombstones, because as they get bigger, they start to square out. But just like always, even though we have our criteria of greater than 1 millimeter of elevation and in contiguous leads, we're still looking for our reciprocal changes. And so where we look for those, typically when we're on an anterior septal STEMI, you're going to see it on the back side over here. And so we look over at 2-3 AVF again, and look what we see. We see depressions. They're a little subtle, but they're there in 2-3 and AVF. And so we'll call this an anterior septal infarct. That means that this blood flow is not going very good, and this whole left side of the heart is really struggling to depolarize like it used to. So this is a STEMI. All right, that's it. So every time we look at an EKG, we're looking at rate. And remember your 3 ways to do that. We're looking at our rhythm. We're asking, is it sinus? Do I see P waves? Is it regular? Axis is our thumbs. Intervals, we're looking at the numbers for QRS and QTC. And then our ST segments. Is there 1 millimeter of elevation with reciprocal changes, or do I see any kind of ischemic changes starting to develop? And that's it. So if we do a practice 12 lead, this is what we see. So let's look at our rate, right? Rate is 81. Do my eyes agree with that? Let's see. This one lines up on a line. So we'll do 300, 150, 100, 75. We're somewhere between 75 and 100. I agree with the computer. Is it sinus? I would say yes. I clearly see P waves, and usually lead 2 is going to be your best place to see a P wave. Is it regular? I can't flip it up right now, but to my eyes, grossly, it looks like they're pretty spaced out pretty regularly. So I would call this normal sinus rhythm with a rate of 81. Next, we move to axis. We're up in 1, we're up in AVF, 2 thumbs up, we have a normal axis. And then our intervals, QRS is less than 120, I like that. Our QTC is less than 500, I like that. We have normal intervals. And do I see any ST segment elevations or depressions? Start looking in my territories, so I look at 2-3 AVF, I don't see anything there. I then move to my high lateral leads, don't see any elevations there. And then I look in the septal and anterior leads. Again, T waves look like they should. They're right at the baseline. I don't see any ischemic changes at all. So what would I call this 12 lead? I would call it normal sinus rhythm. It's got a sinus rhythm with a P wave, rate of 81, normal axis, normal intervals with no ischemic changes. That's how I would interpret that one. And that is it for now. I'm looking forward to seeing you every week, and we'll put these into practice.